Thank you very much. Well, I'm delighted to be here to be able to talk about narcolepsy and to talk specifically about cataplexy. So, in order to understand cataplexy, you first have to understand the normal sleep-wake pattern. So, let me just talk a little bit about that for a start. I mean, as you're all aware, we spend about 8 hours of a day in sleep. And that sleep is not just a unitary phenomena, but it's different qualities are associated with it. And so what we have is that we have deeper sleep and lighter sleep, and we have dreaming sleep and non-dreaming sleep. So typically in a normal night, that's of about 8 hours, what will happen is that we tend to go into the lighter sleep stages, and after about 90 minutes, we may go into the dreaming sleep. Now, it's called the dreaming sleep stage because that's a stage when most dreams occur and they're the most vivid, although we can dream right throughout sleep, even in the non-dreaming sleep component. So we go into this dreaming sleep, which is also called REM sleep, rapid eye movement sleep, about 90 minutes after we first fall asleep at night. And then we have various cycles of dreaming sleep and non-dreaming sleep. We have about 4 or 5 of these through the night, and the amount of dreaming sleep tends to increase as we go through the night, so that the longest episodes of a dreaming sleep occur, prior to our awakening in the morning. Now, during the day, of course, if we have a normal night of sleep and an individual who's healthy and doesn't have narcolepsy, they're going to be awake during the daytime, and there's not going to be any sleep that occurs during the day. So that's the normal pattern that we would see in a healthy individual. So what happens in narcolepsy? Well, narcolepsy is a 24-hour-a-day problem. It's not just a daytime problem, it's a nighttime problem as well. So what we see is that sleep is very disrupted at night. There are frequent arousals and awakenings that occur at night. Our dreaming sleep is not continuous, but it's disrupted. And we also get sleep intruding into the day, so that sleep can occur at any time of the 24 hours. And the dreaming sleep can also occur during the daytime too. But the difference is that the dreaming sleep is more fragmented. It's broken up. It consists of little bits of dreaming sleep, and sometimes it may occur without the full dreaming sleep, but just some of the components of dreaming sleep. Now, dreaming sleep typically, and when we have it at night, it's a time when our brain is very active. It's almost like we're awake, actually. And that's probably associated with the fact that we're having dreams at night. So our brainwave activity is very fast. But at the same time, what happens is that our body is paralyzed during the dreaming sleep. You can't move during the dreaming sleep. And that's probably so that we don't start acting out our dreams at night. So there are several things that occur. There's the dreams that occur, and then there's this paralysis of our muscle activity that occurs when we go into the dreaming sleep. So what causes cataplexy? And what is cataplexy? Well, cataplexy is a manifestation of dreaming sleep. We can think of in narcolepsy of there being 3 main features. One is the disrupted sleep that I talked about. The other is the disrupted REM sleep, which causes cataplexy and causes a lot of dreaming at odd times when we awaken, or during naps during the daytime, for example, and can cause that partial paralysis, the sleep paralysis, so you often call it, where we can get that component of REM sleep where our body doesn't move, and that can occur at any time during the 24-hour day as well, usually in association with either falling asleep or waking up, as does the dreams. And sometimes those dreams occur while we're awake, so that they become hallucinations. So the main features in narcolepsy of this disrupted dreaming sleep or disrupted REM sleep are the hallucinations, sleep-related hallucinations. It's dreams occurring while we're awake, and also the motor paralysis or sleep paralysis. And the third major component is the cataplexy. Now, cataplexy is the muscle atonia or weakness, the paralysis of the muscles that occur while we're awake. And this typically happens when we have some cause for it, such as an emotional stimulus. So the definition of cataplexy is muscle weakness that is caused by an emotional stimulus. So we get emotional while we're awake, so we have to be awake to get emotional, and then we get the weakness that occurs in our muscles. Now, the mechanisms involved in this we know, and we've learned a lot about the control of streaming sleep. But we know that there's part of the brain called the prefrontal cortex, which is the part that's important for our intellectual functioning. But it's also the part of the brain at the front that's involved with emotions. And what happens is when we have an emotion, it sends a signal to some brain cells that are deep in the brain called the amygdala. So it goes from the frontal cortex to the amygdala, and then the amygdala feeds into the areas that are important in the control of dreaming sleep. And those are in the brainstem. The brainstem is the part of the brain, it's at the top of our spinal cord. So that's the area that's most important in controlling our dreaming sleep. Now, when we get an emotional stimulus, if we have narcolepsy, what happens is that it can stimulate a partial manifestation of the dreaming sleep. A person may experience the hallucinations, and that's a partial manifestation of that dreaming sleep. They may experience a feeling of being unable to move, particularly if it occurs when they're waking up or falling asleep, the sleep paralysis. But when it occurs during the daytime, that stimulus can cause weakness in the legs, and the person may feel that weakness in the legs, and at worst, they may fall to the ground. Now, there are many different manifestations of cataplexy. At worst, people will get weakness in the legs, and it'll cause them to drop to the ground. But most people with cataplexy don't get severe weakness in their legs to the point that they fall to the ground, but it can affect other muscles in the body. Now, it only affects what we call the skeletal muscles. So it doesn't affect our muscles that are in other parts of our body, such as obviously the eye muscles, because when we dream, our eyes are moving, so those muscles are okay. Our gastrointestinal muscles are all okay, and our diaphragm's okay, so that we can breathe. But it affects the muscles associated with our limbs and our head and neck particularly. So that some of the manifestations of cataplexy can be in the face. So somebody's face, the muscles may relax and the face looks sort of flattened. The eyelids may come down because the eyelids will get weak, and so you may see some lowering of the eyelids, or what we call ptosis in medicine. And you can also get some slurring of the voice because the muscles around the tongue will also be affected. So when somebody who's having cataplexy, it may affect a number of the muscles around the head and the neck. So the neck may get a little weak, the head may droop, the eyelids come down, the face will flatten, the voice will become slurred. And it may be only very brief and momentarily occur. But it can also affect not only the head and the neck, but also the limbs, so that it can affect the arms as well as the legs. We focus on the legs because that's the most dramatic form of cataplexy, where somebody will fall to the ground if they get very weak, but it can affect the arms, and the arms can go limp. And so somebody may be carrying something, and they may actually drop it because there's a little weakness that occurs in the hands or in the arms. And if somebody is walking and they get a cataplectic episode, they may get a little weakness of the legs and they may catch their toes. So very commonly, patients with narcolepsy will regard themselves as a little bit more clumsy than other people because they will tend to drop things or they may catch their toe or stumble when they're walking. And so that tendency for a little clumsiness is very typical of somebody who has cataplexy. Now, typically cataplexy occurs at the beginning of our narcolepsy. So as you're aware, narcolepsy, we know, is caused by a loss of a chemical in the brain called a neuropeptide called orexin, or also known as hypocretin. And this chemical is lost in the brain, and that's why we get this abnormal dreaming sleep, because that's a very important chemical in controlling our dreaming sleep. And so there is this loss of this chemical. And it causes not only the sleepiness and the disrupted sleep, but also causes this tendency for abnormal dream sleep and causes cataplexy. Now, the median age of onset of narcolepsy is 16 years. So that means that 50% of people with narcolepsy will develop it before the age of 16. So it's really a childhood disorder. Most people don't get diagnosed until they're adults, young adults. And so there's a huge delay from the onset of the first symptoms of narcolepsy until a person will become diagnosed with it. But it's typically, it is really a pediatric disease. I know we've focused a lot over the years on the adults, and that's primarily because our medications have only been approved for adults in most cases. And so the emphasis has been on adults, but it really is a pediatric disorder. Now, when narcolepsy occurs in childhood, usually it's the sleepiness that occurs first. And in children, the sleepiness may be quite different in that they may become hyperactive, and they may be long sleeping at night. And so it's a little bit different to the sleepiness that we see in adults. But also the cataplexy is different when the cataplexy occurs in children. And the cataplexy, which occurs with emotion, so that somebody thinks of something funny or somebody tells a joke or they hear a joke, and they get a little emotional because of that, then they'll get some form of cataplexy, which in children may be manifest in one of two ways. In adults, it's typically hypokinetic or hypoactive, and that the muscles go weak and the face flattens and things reduce. But in children, there can be the opposite symptom. There can be hyperkinetic activity. So that children may actually have a lot of grimacing with their cataplexy, facial grimacing. They may have what we call tongue protrusion. Their tongue may push into the side of their cheek or even outside their mouth. So there can be increased activity occurs with the cataplexy in children. And this tends to go away as the children get older. And it becomes more like the adult form where we get more of the weakness and less of this increased sort of motor activity that we may see in children. Now, as I mentioned, the narcolepsy is often not diagnosed for many years, so that people may have symptoms in childhood and they may be missed or overlooked or misdiagnosed, and then they don't get diagnosed till they're adults. Well, typically it's the sleepiness that occurs first, and then the cataplexy can occur. I mean, in some cases, cataplexy may be the first sign of narcolepsy, so it's not always that the sleepiness occurs first. But the cataplexy can occur many years after the onset of the sleepiness. And that's often why this disorder is difficult to diagnose, because you just have sleepiness to start for most patients. But the cataplexy can come on as much as 12 years or even longer after the onset of the sleepiness. So somebody may be sleepy and then many years later develop this emotionally induced muscle weakness that occurs. Now, in terms of the type of stimulus that causes cataplexy, most typically it is what we call positive emotions, laughter, happiness, hearing or telling a joke, for example. But sometimes it can be negative emotions, maybe anger. And then there can be other emotions that are not associated with either being positive or negative, such as sudden surprise. Someone gets surprised and they may get the weakness in their legs. It can occur also spontaneously. Now, in order to get a diagnosis of cataplexy, you really need to have two emotionally induced episodes for a diagnosis. And that's what the clinicians are going to be looking for, to see that somebody has some emotion that occurs and then they get weakness that follows it. And it may not always be associated with emotion. For diagnosis, it's important to determine that it's associated with emotion, but in somebody who has a lot of cataplexy, they'll be aware that there are times when they don't get emotional, but they will get the weakness. And these are small, what we call spontaneous episodes that can occur. And so somebody may just be doing something around the house and they may get an episode. They may be just thinking of something which is very slightly emotional, and that causes a cataplexy episode. However, if somebody has a weakness episode that's not associated with emotion, it's not enough to make the diagnosis of cataplexy. As I say, you must have at least two episodes of emotionally induced muscle weakness to make the diagnosis. But as mentioned, people who have a lot of cataplexy often do have these spontaneous episodes. So not every episode is going to be associated with emotion. The number of situations that can produce cataplexy is very, very large. It's interesting that although it can occur when people are driving, typically it doesn't occur when people are driving. So many people with narcolepsy can drive and they may get sleepiness come on them and they may stop driving because of that. And but they may not get the cataplexy. But typically cataplexy will occur in any situation when there is emotion. Can occur while swimming, for example, or in the bathtub. People can get cataplexy, may be very dangerous and frightening situations when it occurs. But for most people with cataplexy, it is relatively mild, affecting the head and the neck. It may be just affecting the limbs. I recall one patient who only got the cataplexy when they were introduced to somebody. The emotion of being introduced to someone caused them to get this weakness that the other person wouldn't notice, but the individual noticed it themselves. Okay, so now in terms of treatment, there is a whole variety of treatments that are available to stop the cataplexy. Now, not everybody takes treatment for their cataplexy. Some people find that the cataplexy is very mild and minor, and they don't need any treatment for it or don't want to take treatment for it. But most people find it a disabling and very unpleasant, embarrassing, uncomfortable symptom, and so they want to have something that will stop it. So I mean, people can avoid situations that precipitate the cataplexy, but that's not good to go through your life trying to avoid situations that will precipitate the cataplexy when you could take a medication and go into those situations and not have a problem with cataplexy. So treatment of it has evolved over the years. Originally, we had the antidepressant medications we recognized were helpful in stopping cataplexy. So any of the antidepressant medications could be effective in stopping cataplexy, but there were certain ones that were more effective, and those were ones that we call norepinephrine reuptake inhibitors. What they do is that they increase the neurotransmitter in the brain called norepinephrine, and that tends to stop the cataplexy. And one of those medications that is commonly used is called venlafaxine. And it's very effective. It's also known as Effexor. It's very effective at stopping cataplexy. The problem with venlafaxine is that, as with most medications, there are side effects. One of the not so pleasant side effects of venlafaxine for people with narcolepsy is that it can disturb sleep at night. And in fact, it can disrupt the REM sleep process at night, and so that people may have more movement activity during REM sleep, a situation that we call REM sleep behavior disorder. Also, antidepressants cause other side effects. They can cause cardiac side effects. They can cause irritability, anxiety. They can cause sexual dysfunction. So there are a lot of side effects associated with the antidepressants, even though they are very effective at suppressing cataplexy. But since the use of antidepressants for cataplexy, we recognize that there are newer medications that are even more effective at suppressing cataplexy. And the one that's FDA approved for this purpose is called oxybate. And there are different types of oxybate. There's sodium oxybate, there's low sodium oxybate, and then there's once nightly oxybate. And oxybate is a very curious medication because it affects a neurotransmitter system that's quite different to anything else that's affected in narcolepsy. It's called the gamma aminobutyric acid receptor, GHB receptor. And by affecting this, it can affect narcolepsy in different ways. In fact, it's the only medication that treats all the symptoms of narcolepsy. It can help the nighttime sleep, it can stop the daytime sleepiness, and it can stop the cataplexy. So it has effects on all the major features of narcolepsy. No other medication will do that. But oxybate, when given, can be very, very effective at suppressing cataplexy. Most people on oxybate find that when they get to an appropriate dose, that their cataplexy is completely gone. There are a few patients who, despite the highest levels of oxybate, continue to have cataplexy. Admittedly, it's not as strong as it was previously, but they continue to have it, and it may be unpleasant. And in which case, we often need to add other medications into our treatment in order to suppress that. So we may add an antidepressant. The antidepressants are not FDA approved for narcolepsy. They're off-label use, but we may add that into our regimen with the oxybate in order to completely control it. Typically, for complete control of cataplexy, most patients with narcolepsy who have cataplexy need to be on the highest dose of oxybate, which is 9 grams per night. Now, there is another medication that's FDA approved for narcolepsy and cataplexy, and that is pitolisant. And pitolisant is an interesting medication because it works on one particular neurotransmitter system in the brain, the histamine system. Histamine comes from only one little portion of the brain called, it's got a long name, the tubomammillary nucleus. So a small part of the brain produces histamine, but histamine in the brain is very alerting. But it also influences the mechanisms involved in the control of dreams and REM sleep. So pitolisant is FDA approved for treating sleepiness associated with narcolepsy and also the cataplexy. And patients need to be titrated in dose, but when titrated up, it can be very effective for treating cataplexy. Perhaps not quite as effective as oxybate in treating cataplexy, but for many patients, it can eliminate the cataplexy altogether. So there's only these two drugs that are FDA approved for treating both sleepiness and cataplexy. One, the oxybate, and the other one is pitolisant. The medications that most patients with narcolepsy are on are called alerting medications, and these typically are one of the modafinils, either regular modafinil or armodafinil, or maybe solriamfetol, known as Sunosi. Some patients are still taking traditional stimulants, such as the amphetamines, Adderall, for example, or methylphenidate, which is Ritalin, and there are many different forms of methylphenidate. Those are traditional stimulants. They help the sleepiness, but they don't help the cataplexy. Some situations, they may have a mild effect on cataplexy. If there's a strong pressure for sleep during the daytime, and that is reduced by the traditional stimulants, that may inhibit the development of some cataplexy, but it's only a relatively minor effect compared with the more effective agents such as oxybate and pitolisant. So we use those medications that we call alerting medications to help with the daytime sleepiness, but not to help with the cataplexy. And typically it's either the off-label antidepressants, the oxybate, or the pitolisant that we would use to stop the cataplexy. Now, we're entering into a stage where we're getting new medications becoming available, and I'm sure many of you have heard about the new orexin agonists. I mentioned earlier that in narcolepsy, the cause of narcolepsy is the loss of this orexin, also known as hypocretin, from a specific area of the brain, part of the hypothalamus. And this is probably an autoimmune reaction caused maybe by some prior infection that causes a reaction leading to destruction of those orexin cells in the brain. Well, we now have developed new drugs that affect the receptors for that orexin, and these are called orexin agonists. And there are a number of them that are under investigation of various stages. The most advanced one is one called oveporexton, which is by Takeda. And this drug has just completed its phase 3 studies, which means that they're now going to be applying for FDA approval of this medication, which would take probably another 12 months before it becomes available in the pharmacies. But this medication is extremely effective at treating the symptoms of narcolepsy, particularly the daytime sleepiness and the cataplexy. And it doesn't help so much for the nighttime sleep, such as oxybate does. And in fact, one of the side effects that many patients experience when they first take these orexin agonists are difficulty in sleeping at night. But in terms of the daytime sleepiness, they're extremely effective. In terms of treating the cataplexy, again, very, very effective. Now, so this oveporexton may be the first one that becomes available to us in about a year's time, but there are other ones that are being studied as well. And the second one where we have the most information is one from a company called Alkermes called elixirexton. And this is, again, very, very effective. At this time, we don't have any evidence to show that one is better than the other. So oveporexton and elixirexton are probably equally as effective, but very effective at improving daytime sleepiness and stopping the cataplexy. But there are other companies that are also looking into this, Centessa, Harmony, Eisai, and the list goes on and on. And so I'm sure in the future we may have many of these types of orexin agonists available to us, and we're yet to find out if there are going to be differences between them At this point, we don't see any major differences. There have been some of these medications that have had side effects and have had to be stopped. The studies have had to be stopped and the drugs withdrawn from investigation. So we need to know a little bit more about them in terms of the potential for side effects and longer term side effects. But at this time, it looks as though these new orexin agonists are going to be real game changers in terms of our management of narcolepsy, and particularly treating the symptoms of sleepiness and cataplexy. Okay, so I think I will stop at that point. I think I've covered a lot about cataplexy, which is a major symptom in narcolepsy, and particularly type 1 narcolepsy. There is the type 2 narcolepsy, in which there may be abnormal REM sleep as well, but it isn't as severe enough to be able to cause the cataplexy symptom. And so it's only in the type 1 that we get this cataplexy. So I'm happy to answer any questions that you may have. There's a question here. Cataplexy rates are often reported differently depending on the study. Could be meaning cataplexy rates, weekly cataplexy rates, median cataplexy rates, placebo incident rates, etc. Because of this, it is hard to compare interventions reported differently. Which reporting format do you prefer from a clinical trialist perspective? Is it different from a clinician perspective? Okay, so sort of a research-focused question on how's best to measure cataplexy. And it is difficult. The difficulty we have in assessing cataplexy is, as I mentioned earlier, there are many forms of cataplexy, and some of them are very subtle. There can be the severe episodes where someone falls to the ground, but most people don't do that. And so many of the episodes of cataplexy may just involve drooping of the head, flattening of the face, slurring of the voice, a little weakness in one or other limb. And so when we do research studies, very often all of these different symptoms are sort of lumped together. So you may have one patient who's in a trial who has very frequent severe cataplexy falling to the ground. And you may have another person in a trial who may just have a little bit of facial weakness, a little drooping of the head, and maybe a little bit of slurring of the voice. And so it's nice if the studies can divide up these types of symptoms, and so we get a clear understanding of which particular symptoms help most. I mean, what we don't know is, are all the episodes of eyelid drooping, are they all eliminated by the new drugs? Whereas the episodes of muscle weakness in the legs are not all eliminated? Or is it the other way around? Are all the weakness episodes in the legs eliminated, but not the weakness that occurs in the head and the neck? So we need better ways of really assessing the symptoms in a patient with narcolepsy who goes into these research trials. At the moment, what we tend to do is that we assess the number of episodes of cataplexy that they have every week. And to be entered into most of these studies, you need to have at least 4 episodes per week for at least 2 weeks. So about 8 episodes at minimum in a 2-week period. But it doesn't define exactly what type of cataplectic episode. So again, it may be somebody who falls to the ground 8 times in the week, maybe somebody who just has a little bit of facial drooping that occurs, or somebody who tends to get a little weakness in their arm 8 times in 2 weeks. So there needs to be improvement in the way we assess and how we analyze the data with regards to cataplexy. I think that would be very useful for us to know. But at the moment, it's the weekly cataplectic rates which are the best to assess. And when we use that measure, what we find in the studies is that no matter what type of cataplectic episode it is, it does seem to improve with the new medications that we're assessing, so that the orexin agonists help the cataplexy, no matter what the type of episode is occurring. Now, there's somebody is mentioning here that there is a bimodal onset with the second mode hovering around 36 years of age. Now, this is very, very interesting. We did a study some years ago on 1,000 patients with narcolepsy. And what we found was that the peak age of onset of narcolepsy was age 16. The peak age at diagnosis was 33. Now, for many people, it's very hard for them to be able to predict when the first symptoms began. It may come on very, very gradually over a period of time. So some studies that have just looked at the age of onset have shown a little blip, a second blip in the 30s. Now, it's not clear whether this is to me, it's not clear that this is a true bimodal presentation in the 30s. Personally, I don't think it is. I think it's an artifact caused by the fact that that's around the median time that people are getting diagnosed with narcolepsy, and they become aware, the symptoms become most prominent at that time, but the onset may have been many years earlier. There was just a study that was reported at the World Sleep Congress in Singapore a week ago, and it was on a very large number of patients from China, where they looked at the age of onset. Interestingly, they tend to have a younger age of onset than we do in the United States. They showed an age of onset in about between the ages of 5 and 10, whereas our median age of onset is around 16. So they tended to be picking it up. Whether we're missing the early onset in younger people or not, I don't know the answer to that. Or whether it is different in China, that they tend to develop narcolepsy at an early age. Now, they showed a huge blip of age of onset in the childhood years, and there was a sort of a minimal evidence for any secondary blip in the 30s. There was perhaps a very slight increase, but it was pretty minimal. And so I think data on larger numbers of patients and a more accurate assessment of the age of onset versus the age at diagnosis, I think that's going to show that the median age of onset is in childhood, and that this bimodal peak is really just an artifact of diagnosis and not a real secondary blip in terms of age of onset. Now, another question we have here. My worst cataplexy involving falls, for instance, seems to be when I am overall exhausted. It seems that when I'm somewhat more well-rested, my episodes of cataplexy are fewer. Do these things match with facts? Yeah, well, I think that when we tend to get exhausted, what happens is that we become more relaxed and sleep is more likely to occur. I mean, if you are deprived of sleep at night and you haven't had an adequate amount of sleep and you get exhausted and relaxed during the day, the chances are you'll fall asleep, and in individuals who don't have cataplexy, for example. So that relaxation is likely to be cause a tendency for cataplexy, because there may be an increased drive for sleep. In order to have cataplexy, you've also got to have a combination of emotion plus increased drive for sleep. But as I mentioned earlier, there are some patients who it's not always precipitated by emotion. Emotion's important for diagnosis, but people with frequent cataplexy will often get it in other situations. And when more relaxed, they're going to be more likely to have cataplexy. And so getting a good night's sleep and being more refreshed and reducing some excess drive for sleep during the daytime can be helpful in reducing the likelihood of having cataplexy during the daytime. Another question. My doctor is unsure about putting me on oxybate along with the Effexor and Suboxone because of the respiratory concerns. What are your thoughts? Well, I think the oxybate and Effexor is a good combination that is often used, and there is no problem there. The difficulty in your case is the Suboxone, and there may be some interaction with the Suboxone. And I think there have been patients who have taken all three of these and have done well. I think your doctor is right in being cautious about it. We do know that there is a slight tendency for respiratory depression with oxybate, and that some patients who have a predisposition for sleep apnea, when they're put on oxybate, it may actually cause an increase in sleep apnea. So anyone who's on oxybate and they've noticed that they're developing more snoring or episodes of gasping and choking, definitely should bring it up to their doctor, and they should get retested. And it may be the oxybate which is precipitating that. And in combination with the Suboxone, there's a potential that there may be some respiratory depression. So anyway, I think I have to leave it up to your doctor to make a decision about this. I can't advise you. It's your physician who knows your overall health situation, obviously a lot better than I do. So, but I think it's right for him to be a little cautious. Okay, another question. My worst cataplexy involving falls. Oh, I mentioned that one. Okay. Is muscle weakness not considered part of sleepiness itself, being more in line with fatigue? Well, when we go to sleep at night, as we go through the various sleep stages, our muscles do relax. They're most relaxed, as I mentioned, in the dream sleep. But there is some relaxation, obviously, of muscles when we get into deeper sleep, or what we call non-REM sleep. So that as we get sleepy, yes, we will get some weakness. However, I mean, most people are not going to be falling to the ground when they're awake. I mean, when you go to sleep, you're going to go into non-REM sleep. Somebody without narcolepsy will go into non-REM sleep, and they will get some relaxation of their muscles. They won't typically go into the REM sleep, the dreaming sleep, unless they've been deprived of it. I mean, if somebody who doesn't have narcolepsy wakes up at 3 a.m., whereas they normally wake up at 7 a.m., they're going to cut themselves short of that dreaming sleep. As I mentioned, the normal situation is for most dreaming sleep to occur at the end of a night. So if you wake up early, and you're going to have less of that dreaming sleep, and there may be an increased tendency for that dreaming sleep to occur during the day, and somebody may fall asleep and go into the dreaming sleep during the daytime. And so they may get severe muscle weakness. But cataplexy is associated with emotion, as I mentioned. You have to be awake to have cataplexy. Patients, when they have cataplexy, are fully alert and awake. Well, not fully alert. They may actually be somewhat sleepy, but they are awake. They're aware of what's going on around them. If the episodes of cataplexy persist, the person may actually go into full dreaming sleep. So it's not uncommon for someone who has severe cataplexy to fall to the ground, be awake, be aware of what's going on, and then actually fall asleep and be in full REM sleep. Typically, most episodes of cataplexy are only brief in terms of minutes, and then that person would sort of come out of it, and they would awaken. But it may lead, a cataplexy episode may lead into REM sleep. So yes, there is some muscle relaxation that occurs when we get tired and sleepy, but typically you need the emotional stimulus while awake to induce actual cataplexy. So another question here after okay, I think I've discussed that. Cataplexy frequency seems to have a wide variety. Be random, spontaneous, non-repeatable. Any thoughts on why this persistent wide variability? Uh, Yeah, it is. It from one person to another can be very, very different. I mean, there are patients who, untreated, have almost continuous cataplexy right throughout the day, intermittent episodes of cataplexy throughout the day, and other people that may only have one or two episodes that they're aware of in their lifetime, or a few episodes that they're aware of. And cataplexy may be mild and it may be severe. So yes, there's a lot of variability, and I don't think we fully understand this. It may be related to how much destruction of that or those orexin neurons there are. Not everybody's going to have all the orexin neurons destroyed by this autoimmune process, and in fact, there's evidence that there are some orexin neurons in part of the brain that are still intact in people who have the majority destroyed by the autoimmune process. So that amount of remaining orexin neurons may vary from person to person. Perhaps that will give us the reason for the variability in the severity of the cataplexy from person to person. Can you clarify how cataplexy influences REM, rapid eye movements? Well, cataplexy is a partial manifestation of REM sleep. It is the weakness that we have of REM sleep. So, as I mentioned, in narcolepsy, what happens is REM sleep's not cohesive. It's not all together as it is in individuals who don't have cataplexy, but it's fragmented. So we get these isolated pieces of REM sleep. So we may get the dreaming while we're awake. We may get the muscle paralysis while we're awake. So different parts of it can occur, and that's why we have fragmentation of the REM sleep. But so cataplexy is a manifestation of this disruption of REM sleep. Can the loss of function of orexin producing region of the brain be progressive? Very good question. Interesting question. Yeah, we don't fully understand that. I mean, there is one case reported of a patient who had normal orexin levels in the spinal fluid, and they didn't have features of narcolepsy, didn't have cataplexy, and they were diagnosed with idiopathic hypersomnia. Then 2 years later, they were shown to have features compatible with narcolepsy, with sleep onset REM periods on the testing, and they got a diagnosis of narcolepsy. And then 2 years after that, they developed cataplexy, and the orexin level was shown to be low in the spinal fluid. And it's called a case of progressive narcolepsy. So yes, there may be further destruction of the orexin neurons. All the evidence points that the major sort of insult to the orexin neurons occurs at the beginning, so that most destruction occurs when we first get the onset of the illness. But there is evidence, such as I just mentioned, that there may be some progressive loss of orexin in some people. And this may explain why there's a delay between the sleepiness and the onset of cataplexy for many people. Maybe there is a progressive loss of orexin, and that's why cataplexy is appearing at a later date. That's why it's very important for clinicians to keep assessing patients who don't have cataplexy as to whether they are developing it, because it's possible it may develop many years later. Will all children with cataplexy develop narcolepsy? Yes, a cataplex. In order to have cataplexy, you have to have narcolepsy. You can't have cataplexy without narcolepsy. So yes, if a child has cataplexy, they have narcolepsy. I think the question might be asking about the sleepiness. There may be differences. There may be some children that have severe cataplexy and don't seem to have much in the way of sleepiness, and this may become more manifest later. It's pretty rare for people to develop cataplexy as the first symptom without any sleepiness and then develop the sleepiness later. But it can occur and has been reported. So it's quite possible. But if somebody has cataplexy, emotionally induced muscle weakness, then it will be narcolepsy. However, there are other conditions that can cause weakness in the limbs, and that can be confused with narcolepsy, other neurological disorders. So it's important for your doctor to assess and make sure that there isn't any other medical condition. There's a condition called hyperexplexia, for example, in which there can be weakness with emotion in the limbs, and it's not narcolepsy. But if it's cataplexy, then it is narcolepsy. Patients having, have you heard of patients having an aura before the muscle weakness? Definitely. Many patients with narcolepsy are aware that something is happening, and they are aware that they're going to have an episode of cataplexy. That's why for many patients with cataplexy, they're able to get to a chair and sit down, and they don't just suddenly fall and injure themselves. So although injuries can occur with cataplexy, most often they don't, even though the person falls to the ground, because they have a sense that something is happening and it's coming on, and they have this aura before, and they're able to get themselves to a chair before they go into a full cataplectic episode. Also, in many cases, a family member may notice a change in the individual before the individual themselves is aware of it and know that the person's going to go into a cataplexy episode. So it may be seen, there may be change. Maybe it's this flattening of the face or some change in the facial expression that is being perceived by a family member before the person who's experiencing it is actually aware that they're starting to enter into a cataplexy episode. Does the age of onset correlate with hormonal changes? Well, possibly, but as I mentioned, in China, they're showing a much earlier age of onset before the adolescent sort of hormonal changes are occurring. So it may not have anything to do with our developmental hormonal changes at all. But we don't know the answer to that as to how hormonal changes may influence the onset of cataplexy. How does one know the difference between sleepiness and cataplexy? That's a good question. It's not always. Very often patients feel that a sleep attack is cataplexy. And so it may be confused. What's the difference between cataplexy and sleep attack? A sleep attack typically occurs when a sudden sleep is coming on quite rapidly. The patient can't give into it. It's irresistible, and they will tend to fall asleep very rapidly. Whereas for a cataplexy episode, it has to be some sort of, in most cases, it's some stimulus. I mean, it may be spontaneous, as I mentioned, may be very difficult. A person may have a sleep attack that's REM sleep, and they may get the weakness, and that's typical of cataplexy, but then they're going to go into sleep. Cataplexy, typically you're awake during the episode. It's an emotionally induced muscle weakness while you're awake. And so there is a slight difference, but the two do mix together, and it's not always easy to differentiate between a sleep attack and an episode of cataplexy. Can cataplexy be triggered by stress in the workplace? Any stress can potentially precipitate cataplexy. So whether it's in the workplace or in other situations, yes, that can cause cataplexy. Is reducing cataplexy more important than improving daytime sleepiness or nighttime sleep? That depends on the patient. I mean, if a patient is having episodes, and I'm thinking of one patient now who had to wear a crash helmet because they were having falls while they were out in the street, and there was concern about hitting the head. And so the cataplexy was very severe, and more severe than the sleepiness in that particular patient. So it does vary from patient to patient. In other patients, as I mentioned, may be very subtle and may not be a problem. So it does differ from patient to patient. But sleepiness may be the most severe. Certainly sleepiness is the more difficult symptom to treat in narcolepsy. We can certainly improve it, but it's very hard to eliminate every bit of sleepiness and the cognitive impairment that may be associated with that sleepiness. A little easier to treat the cataplexy. For most patients, we can stop the cataplexy completely. Okay, so someone say that their child has cataplexy and they will grab his arm when he's going into a cataplectic episode, and that helps bring him out of it. In some cases, that may be true because what's happening is that there may be this sort of drive for sleep. It may be reduced alertness, allowing partial manifestation of the REM, the dreaming sleep that occurs. And so by grabbing his arm and giving some sort of alerting stimulus to the person may actually help prevent them going into. Typically, though, this doesn't occur, but it can occur, and it's probably by increasing their alertness to sort of ward off that drive for the dreaming sleep, of which cataplexy is a partial manifestation. What are the key differences between sleep paralysis and cataplexy? Both of them are muscle weakness that occurs as a manifestation of partial REM sleep. The difference is that sleep paralysis typically occurs as we're falling asleep. So it's a sleep drive that produces sleep paralysis, or when we're waking up, we have from having been asleep. So that sleep is the cause of the weakness, and we're aware of the paralysis as we're waking up, so we're awake and we're aware of it. Whereas the cataplexy, as mentioned, is the emotionally induced and typically will occur out of a setting of wakefulness, not occurring as we're waking up or as we're falling asleep at night. If it occurs, weakness occurs at those times, if it's unlikely if you're falling asleep that it's going to be associated with some emotional sort of stress. But if you do get that weakness as you're falling asleep, then it's more likely sleep paralysis, not cataplexy. Okay. Have there been efforts to study cataplexy for psychological therapy techniques? So somebody's asking about, because it's emotional, dealing with emotional precipitants can be, would that be helpful in treating cataplexy? The answer is that yes, by avoiding emotional stimuli, it certainly can stop cataplexy. But it's sort of not pleasant to think that you got to go through your life trying to avoid emotional stimuli that are going to cause cataplexy. Some patients do this and don't take medications. Patients that don't want any medications, when they know there are certain circumstances that precipitate their cataplexy, and they'll just go through life avoiding those circumstances. But for a full, active, healthy life, I think you need to be able to give full range to your normal emotions. And therefore, that's why it's probably best to be on medication that will stop the cataplexy so that you can go somewhere, hear a joke and tell a joke and laugh and be happy and get some sudden surprise without having a cataplectic episode. So in most cases, medication is required. Okay, so I think time is up, so I'm going to stop at this point, and thank you very much for your questions and your interest in this very interesting topic of cataplexy.